Hello and welcome to the latest seminar from the Glasgow Centre for Population Health, supporting new approaches to improve health and tackle inequality. At this chaired presentation and discussion, we explore health inequalities and ask what's changed and what now. This event was chaired by journalist Danny Garavelli. Presentations were made by Dr. David Walsh, Public Health Programme Manager at GCPH, Professor Jerry McCartney, Professor of Wellbeing Economy at the University of Glasgow, and panel members included Donna Milne, Director of Public Health and Health Policy NHS Lothian, and Dave Moxham, Deputy General Secretary of the STUC. This seminar was recorded in front of a live audience in Glasgow as part of the GCPH Seminar Series on the 23rd of November 2023.
Welcome everyone to this Glasgow Centre for Population Health seminar, in which Dr. David Walsh and Professor Jerry McCartney will explore Scotland's deepening health inequalities, highlight the political drivers, and look at policies which could help reverse the trend. My name's Danny Garavelli, and I'm a freelance journalist who specialises in social justice issues. I'm delighted to have been asked to chair the event. To be honest, I say no to almost anything that requires me to stand up in front of people, but I said yes to this because health inequalities and the low life and healthy life expectancies of our most deprived populations is something I feel deeply invested in. Last year, the work of the Glasgow Centre for Population Health formed the basis of a chapter I wrote for the Joseph Rowntree Foundation-backed book Broke about deepening poverty across the UK. So I know how crucial a role the GCPH has played in analysing and exposing the problem, and I'm as keen as everyone else to hear more about the research and the possible ways forward. Before I go any further, there are, as always, a few brief housekeeping points to cover. There's no planned fire alarm. If the alarm does sound, the staff of the TIC will direct people to the nearest fire exits and muster points. The toilets are located on level 1, which is this floor. Could you please make sure your mobile phones are switched off or on silent? And if you're tweeting, could you please use hashtag GCPHSEM20. That's GCPH all caps, SEM with a cap S at 20. Finally, the seminar is being recorded and will be available without audience questions on the GCPH website shortly after the event. The link will be emailed to you when it's been published, and please feel free to circulate it to all your colleagues. So back to the seminar itself. First of all, this afternoon we'll hear from Dr. David Walsh and Professor Jerry McCartney. David is a public health programme manager at the CPH. He's responsible for leading a number of different research programmes within the centre. Recently, this has included a large body of work aimed at understanding Scotland's and Glasgow's excess mortality, studies of deindustrialisation and health across European regions, and other collaborative research into the nature and causes of and solutions to health inequalities, all of which he's about to talk about. Jerry graduated from medicine at the University of Glasgow and did his GP vocational training in Paisley. While working as a junior doctor, he completed an honours degree in economics and development at the University of London. After this, he entered the public health training scheme based initially at NHS Argyll and Clyde and then at NHS Greater Glasgow and Clyde. During this time, he worked on the 2007 E. coli outbreak in Paisley, performed needs assessments for communities in the East End of Glasgow, and did his MD at the MRC Social and Public Health Sciences Unit on the impact of the Commonwealth Games. He also worked at the GCPH, where he produced the first synthesis of the causes of excess mortality in Scotland and Glasgow. After their presentations, I'll ask a couple of questions and then invite a response from our two panellists, Dave Moxham and Donna Milne, who I'll introduce properly later. We'll also have some time at the end for questions from the audience. So now if I could just invite David to come up.
Okay, thanks, Danny. Can everybody hear me? I also tried to say no to speaking, but I work for the organisation, so they wouldn't let me. So this is the 20th seminar series, which is a bit scary because I remember being at the first one, which was 20 years ago. And obviously in that time, there's been a whole series, a whole run of esteemed, influential and actually inspiring speakers, and it's terribly sad that that comes to an end today. There's a couple of other things I'll just say quickly. So Jerry and I are doing a kind of tag team thing. It's like a kind of presentational version of Bad Cop, Good Cop, in the sense that I'm going to kind of do a lot of bad news by describing what's been going on, and then Jerry's going to give you a more kind of optimistic slant on how we respond to that. And I'm just saying that because as I take you through the slides and you feel a sense of increasing relentless misery and doom, just remember that some good news is round the corner or sitting over there. And also, I was asked to include quite a lot of stuff, so there is quite a lot of stuff. So my solution is always to get through this in a manageable time is just to present it very quickly. So just try and keep up if you can. So we're going to ask 3 questions. The first is what's happened to health inequalities over the last 20 years? And I suppose as part of that is also what have we learned over those 20 years? The second question is then, why has that happened? And then, as I said, Jerry will be talking about what do we do about it. I'm going to kind of give you the answer before I go into all the details. So a little bit like the news before sports scene or match of the day. If you don't want to know the result, look away now. But in essence, they're not kind of happy answers. I did have a more profane answer, but I was asked to tone it down. And the answer to why that's the case is because of politics, because of political decision making. And what I'm going to try and do is frame what I'm talking around around 4 examples of that, okay? And I'm hoping this will make some kind of sense. I don't need to worry about the third question because Jerry's going to deal with that. So, years ago when presenting to different groups, and especially if it was groups or students that were from different countries, I used to always kick off these talks by asking the question, what do you think of if you think of health in Scotland? I stopped doing it because there's only so many discussions about the deep fried Mars bar that you can have in one lifetime. And so instead I kind of kick off these talks by saying, well, if you work in public health, one of the things you think of is maybe headlines like this, the sick man of Europe. This is a frequently used headline in the Scottish media, as you can see. And one of the interesting things about it, I think, is that if, unlike a lot of the stuff you read in the Scottish media, especially open inverted commas newspapers, like the one in the middle, is that it is, as you know, true in the sense that if you look at some kind of summary measure of population health, like life expectancy, as everybody in this room knows, Scotland lags behind all the main kind of Western European countries, and that's true for men and for women. What a number of people in this room will know, but maybe some don't, is that part of the explanation for this lies with a much slower rate of improvement over time. So this next chart, and if you've seen this before, this is updated. This next chart shows long-term trends in life expectancy, male and female life expectancy, for all the main Western European countries, and this goes all the way back, to the middle of the 19th century, more or less to the present day, just before COVID hit. And every red line is obviously one of the main Western European countries. And if we just highlight the trend for Scotland, there are 2 important things to note. The first, as the slide said a second ago, Scotland has not always been in this position of having lower life expectancy than the other countries. From about the middle of the 19th to about the middle of the 20th century, we were kind of in the middle of the pack of all these countries. But then what happened over the next 6 decades or so is that although things generally continued to improve, they improved more slowly, meaning that by the end of the period, we are in this position of having the lowest life expectancy in Western Europe. Now, there's 2 other quick things to say. The first is there's an obviously really weird change in the trend in the most recent decade, and I'm going to pick up on that in the second half of my contribution. And the other point to note is that general divergence of Scotland from the other Western European countries has been particularly acute since around the start of the 1980s, or to be more politically accurate, since about 1979. And I'm going to pick up on that as well. So the first kind of political framing, if you like, of trying to understand these trends is the fact that life expectancy in Scotland is comparatively low because of the impact of inequalities. Scotland has lower life expectancy than elsewhere in Western Europe because we have the widest health inequalities in Western Europe. So the gap in health terms between rich and poor is much wider here. And if you think about it, that therefore pulls down the overall average. And I can throw lots of stats at you to show that that's the case. This is a study from 10 years ago. Don't worry about the detail. It's just showing that gap in health terms between rich and poor is indeed much wider here than elsewhere. This is a different measure called lifespan variation. For the sake of audience sanity, I won't try and define it, but it's basically a kind of proxy for inequalities in life expectancy, how much life expectancy varies across the population. And as you can see, Scotland stands out from these same Western European countries that we're looking at. And the really important point is that those same health inequalities have widened consistently and considerably over that period in which Scotland has fallen behind all these countries. So again, if we go back to this measure of inequalities in life expectancy for all these same European countries, the early period doesn't really matter so much, but I'll just explain it so you understand the chart. Back in the middle of the 19th century, obviously lots and lots of people died very young, so you had a huge gap across society in life expectancy. And then as living circumstances improved, health improved, that dropped dramatically and consistently across all countries. But by the time we get to 1979, the UK as a whole, but much more, this blue line, Scotland, bucks the trend in terms of increasing health inequalities over the period, both in absolute sense and obviously also relative to these other countries. And that's really important because that's what drives that trend of Scotland falling away from the rest of Europe as the overall average is consistently pulled down. Why has that happened? Well, it's happened obviously because of the profound link between socioeconomic circumstances and health, between socioeconomic inequalities and health inequalities. And over that period, society has become a profoundly different place, a profoundly more unequal place. Scottish society, but also the UK society as a whole. And again, I can throw lots of stats at you to back that up. I can show you different trends in socioeconomic inequalities. This is a kind of sub-part of that in the sense of looking at income inequality, not around health, but just generally in society, the gap between rich and poor. And back in the 1960s, this measure of inequality in Britain was jumping about a lot, but it was low and it was going down effectively. And then from 1979, society just changed completely and became a much, much more unequal place. And it's maintained or worsened that ever since, to the point where across all these countries, Britain as a whole is the most unequal society. And clearly, at the risk of patronising the audience, that has been caused by political and particularly economic decisions that have driven all that. So it was particular governments that drove that initial increase, but that's been followed by other governments which have maintained or indeed worsened that position. I always forget about her. I actually did have some amusing pictures of some of these prime ministers, but I was advised to take them out. I don't know why. I think maybe it was the one with Cameron with the pig that was proven a bit too offensive. However, in understanding inequalities, we also have to understand that in Scotland, and particularly parts of Scotland, there's also a bit more to it than that. So there are other influences on top of those big UK-wide macro effects, which also further widen inequalities. But those influences are all still very, very political. And so this is the second of the kind of political framings, if you like, that I want to talk about in terms of understanding different regional trends. So going back to this chart, this is when the seminar series and GCPH itself kicked off. And at that point, as we were working with GCPH, it was clear that that divergence was becoming quite acute. And we were trying to understand, apart from these kind of UK trends, what else was driving that? Country comparisons can be quite tricky, though, because obviously, especially in an unequal country, you have people living in quite different circumstances. And in Scotland's case, it was really important to understand the particular deindustrialised nature of society, which also drives different kind of health outcomes. So we were looking at this in terms of not country comparisons, but rather trying to understand differences across other post-industrial parts of Europe to give us a bit more of an insight. So to introduce this, and I won't go into detail, but to introduce this is looking at inequalities in life expectancy across the 32 local authority areas of Scotland. As in any high-income country, we're not an exception in this case. The areas with the worst health are those which were previously very industrial, but which have since suffered profoundly from the effects of deindustrialisation, the loss of so much industrial employment over the latter half of the 20th century. All bar one of these, Dundee, is obviously located in the west central Scotland conurbation where we are today. And in this study, which is now a good number of years ago, we were comparing health and health inequalities in this area with lots of other parts of Europe which had also experienced broadly similar levels of deindustrialisation. And the thinking here was to try and come up with more meaningful like-for-like comparisons rather than just those kind of harder country comparisons. All that said, the analysis basically showed very, very similar results to the country comparisons in the sense that at that time, although life expectancy was again improving in the Scottish area, it was doing so more slowly, or it was dragging behind all the Western European post-industrial areas, and had actually been overtaken by the Eastern European industrial areas. So again, we were kind of bottom of the heap. And in trying to unpick the reasons for that, we did all of the usual kind of quantitative analysis in terms of data collecting and number crunching and tree killing, because we killed lots and lots of trees and reporting all this, which was probably unnecessary. But actually, some of the main insights came from more kind of qualitative work, looking at different kind of policies. But in combination, the totality of all the work just showed that the reasons for differences in health across all these broadly similar places was just all about different politics. It was all about different political decision making and the extent to which they protected or did not protect health. So from the number crunching, we showed that income inequalities was again higher in the Scottish and the other UK areas. And again, that's important because it drives wider health inequalities, pulls down the overall average again. But more broadly, there was just lots of evidence of better political decision making in these different parts of Europe compared to the UK and particularly compared to the Scottish area that we were interested in. I'm not going to go into detail, but just very, very quick examples. In the French area we looked at, which was an ex-mining area in the north of the country, there was good evidence that they had seen the threat of deindustrialisation much earlier, had responded much quicker and diversified their economy into different technologies, meaning that they protected employment, therefore protected wages, therefore protected against poor health. In the Polish area, they just had better state investment, and they also mitigated against the effects of deindustrialisation by increasing levels of social security to protect the income and therefore the health of the poorest and the most vulnerable during that transition. Very similar things happened in the Czech area we looked at, where they also managed to retain a lot more industry and therefore protect employment, protect wages, protect against poor health. And in the German area, there was, again, evidence of better investment, better planning, etc., etc. So it wasn't that all these different places did the same thing to be better than the Scottish place, but there was an underlying overall theme that it was all about better politics. However, on top of all that, and again, in understanding the scale of inequalities where we live, from the national to the regional to the city level, in Glasgow's case, where we are today, there are other city-level influences, again, on top of those other factors that you have to understand the scale of inequalities. But yet again, we've shown in the stuff that we've done with GCPH over the years that all that is also political. So this is the third of the kind of political framings, if you like, and this is about excess levels of deaths, why mortality rates are higher than you might expect them to be in Glasgow. And this is what the media refers to as a Glasgow effect. What we refer to as excess mortality. If you take only one thing from this seminar, other than the amount of information I'm going to throw at you at a rapid pace, it's not to use that term because it's quite a meaningless, pointless term, and I'll come back to it just in a few seconds. To introduce this part of the talk, just go back to this slide of life expectancy across these 32 local authority areas. And you don't need me to tell you that the area with the lowest life expectancy is obviously where we are today. But a really important point about that, away from talk of a Glasgow effect or anything else, is that the main cause of this is just poverty. Poverty is the main driver of poor health in any society. It doesn't matter if it's Glasgow, it doesn't matter if it's anywhere else. And just to hammer home that point, if we put that slide up in the top and just label it life expectancy and then pull in some data for these same areas, which are basically data on poverty or deprivation, you see that one is basically a mirror image of the other. Wherever you have high levels of poverty, you will have worse health, and in this case, lower life expectancy. And just to labour the point and move beyond Scotland, if you plot a measure of poverty along one axis and life expectancy in the other, and you throw in the main UK towns and cities, you see the tragic truth of the matter is that the greater the level of poverty in society, the younger on average people die. But the issue for Glasgow is it's always been a bit of an outlier, and we spent quite a lot of time working with GCPH in terms of understanding why it was so different from other broadly similar cities like Liverpool and Manchester. And the answer, you won't be surprised to know, but which we published in the world's longest report in 2016, was, again, it was just all political. In this case, it was about a whole series of historical political factors that had placed Glasgow at a much greater disadvantage to these other broadly similar places. This in itself is about a 45-minute PowerPoint presentation, so I'm not going to go into the detail of it. But in essence, there was a whole set of historical factors the research showed which had placed this disadvantage on Glasgow. It related to lots of things like the fact that living conditions were worse in Glasgow historically anyway, and that's relevant in terms of understanding adult health then, but also adult health today. In part consequence of those worse living conditions, there was evidence that changes made by local government in the post-war decades had a much more detrimental effect on the people of Glasgow in comparison to other cities like Liverpool and Manchester. This related to lots of things like the sheer scale of slum demolition and slum clearance, and that's important in the sense of how it broke up existing communities. It related to issues like building really, really, really poor quality housing. This kind of housing was done across Britain, but the evidence showed it was done on a much larger scale in Glasgow, housing and affecting a lot more people in absolute and proportionate terms. It related to building a lot more multi-storey flats, relevant because of the evidence in the research literature linking this type of high-rise living to poor mental health, and there are clear evidence links between poor mental health and poor physical health, and we've just built a lot more of them. And fundamentally, it was also just about investing less money in key points in time in actually repairing and maintaining and looking after these places where people lived. So to describe this more simply, looking across these three cities at different points of time, although they all had similar levels of income-based poverty, people in Glasgow were just living in worse conditions, which obviously has hugely important knock-on effects in terms of health. On top of all that, there was lots of other things going on. There was evidence about actions by the Scottish Office, which also had detrimental effects in terms of economic investment being moved out of the city and there being a socially selective movement of people as well, which had an impact on the composition of the remaining population. I don't have time to go into that today. And by the time we got to the 1980s, there was also evidence that at that time, a period of deindustrialisation, of widening inequality, of increasing poverty, that there were differences in how local government responded to those major challenges of the time. And without getting into detail, in essence, there was a lot less done in Glasgow than the other places to actually looking after the poorest populations. So it's a very complicated story. There's lots of different historical nuances, but it can be summarised, I think, effectively as it was all about politics. And maybe a subheading is what that means is there's no such thing as a Glasgow effect in the sense of there being something different about people in Glasgow. It's just another example of a political effect on health, of which all the things I'm talking about today are further examples of that. As a quick aside, when we published that report in 2016, I spoke to lots of journalists, not Danny, but lots of journalists at the time, and tried to explain why this term Glasgow effect didn't really mean anything and was actually quite an unhelpful thing, and asked them not to use it in the coverage of all their reporting of it. And it was terrific how they responded by not using it, apart from in every single headline that there was. However, that's journalists for you, no offence. Okay, however, Jerry and I are doing a lot of writing at the moment, and he slags me off for using particular words too frequently, and one of them is however. But however, to bring this up to date, all of that stuff, all that kind of historical stuff that we kind of unearthed during those basically the last 20 years, I think is arguably overshadowed by what's been happening much more recently. And the impact of political decisions on health inequalities more recently is arguably worse than what we've seen in that longer period that we've been talking about. And this is referring to what I showed you earlier as this kind of weird change in the life expectancy trend in the most recent period. This has been referred to as a stalling of improvement of life expectancy. And I think language is really important here because I don't really think a lot of people quite understand what's been going on. But indeed, the background to it all lies with headlines that were appearing prior to the pandemic about that very thing, a stalling of improvement in life expectancy, both in Scotland but also in the UK. And as I say, I'm pretty clear that people reading that maybe didn't know what it meant, and even if they read the detail of the articles, which was saying that life expectancy was now no longer going up quite as fast as it was before, probably thought, well, does that really matter? Is it a big deal? But if you were working in public health, this was ringing all sorts of alarm bells for the very simple reason that in a wealthy society, be that Scotland, be it the UK, it just shouldn't happen. Life expectancy should still be going up. And conversely, mortality rates that I'm going to show you, which are based on exactly the same data, should still be coming down. Because the only time that's not happened, going back over 100 years, as you can see from that last slide, have been times of profound societal crisis, times of war, times of pandemic. So this caused lots of people, including ourselves, to try and dig into what was going on, dig into the data to see what was going on. And what emerged from that, I think, is pretty horrendous. So I'm going to start deliberately with England. because an important part of the story is that it's not just about Scotland, it's a kind of UK-wide issue. And I'm going to show you mortality rates for females of all ages, but it's the same picture for males. And this is the long-term improvement going back decades and decades. So basically people living longer, this goes back to the 1980s, but you could track it back decades and decades before that. And in the early 2010s, you get this so-called stalling of improvement, this levelling off, this kind of slowdown. What's really important is that this isn't about those living in the least deprived areas. There is a slight change in the trend, but importantly, mortality rates are still coming down. But it's very much about those living in the most deprived areas, where barely believably, mortality rates stop coming down and actually start to go up. At the risk of labouring the point, in a country as rich as England, this just shouldn't happen at all. And this isn't the 1% or the 2% most deprived populations, those on the periphery. This is a fifth of the population of England, for goodness sake. The picture in Scotland, on a slightly different scale because mortality rates are a wee bit higher to start with, is exactly the same. Increasing death rates among the 20% most deprived areas in this country. If you dig into the data, you see really sharp increases in female premature mortality rates among those living in the most deprived areas. If you look at these exact same data for this city, Glasgow, you see a dramatic reversal of previously sharply falling mortality rates among those living in the poorer areas of the city. All these charts take us up to COVID, by the way, but I'm going to update this one in a second just to show you the impact of adding in the two peak COVID years. If you go to Edinburgh, Edinburgh's a fabulously wealthy city, so why have we got increasing death rates among men of all ages, among those living in the 20% most deprived areas of that city? And if you look at male premature mortality, there's just dramatic things going on, for example, in Dundee. And as most of you will be aware, all of these changes have coincided with the UK government's austerity agenda, which sought to cut, frankly, astonishing amounts of money from public spending, including vital public services that everybody relies on. But included in that, and more perniciously, is cuts of tens and tens of billions of pounds from social security. Social security in a civilised society is a safety net for people living in difficult circumstances. If you take that safety net away, what happens? Well, what these data suggest are that people die, and they die in increasing numbers. And that now then becomes quite emotive language, and so we have to be very careful in public health in terms of what we are saying is actually supported by the evidence. Is it evidence-based? But the answer to this question now is just a huge yes. It's yes to all the international evidence that now exists around the impact of austerity. It's yes to all the UK evidence. It's yes to all the Scottish evidence. If you don't believe there's lots of evidence, there's lots of evidence. And in a report we published last year, led by Jerry, we did a critical assessment of all that evidence, and it showed very clearly that the main drivers of these frankly appalling trends have indeed been UK government austerity measures, which have impacted particularly on the poorest and the most vulnerable in our society. As a quick aside, in a departure from our usual activities of writing reports like this that frankly nobody reads, we also produced a 3-minute animation with a great company called Media Co-op, which is basically the same evidence but in a much more accessible format, and I would encourage all of you to have a look and share it if you can. I said I'd update one of these trends, and there's a particular reason I want to do this. So this is to include the two peak COVID years, and this is the one I showed a minute ago for Glasgow and premature female mortality, the one with this dramatic reversal of previously sharply falling mortality rates. So it's no surprise that if we add in the two peak COVID years that these trends basically become worse. But the point of showing this is actually just to pause for a second and kind of take a step back. Because what this is showing is that in Glasgow, a city renowned for poor health and high mortality rates, if you go back over a decade, what we had was kind of a bit of a success story in the sense for this particular population, mortality rates were coming down, but they were coming down more sharply in the most deprived areas. So that's a picture of narrowing inequalities, if you like, what we're all trying to seek to see and to achieve. And then you fast forward through over a decade of austerity, and what we have now is death rates are higher in the most deprived areas than they were 20 years ago. This is totally unprecedented. I don't think enough people are aware of it, and it's also just frankly horrible. That impact of austerity, I think, is quite hard to overstate. We've been doing a lot of work in this area. But if you just think of a few things like food banks are everywhere, they're in the news, they feature, you see them every week at the supermarket, etc. Prior to 2010, they didn't really exist. There's been analysis done by people at Heriot-Watt University just showing they didn't really exist prior to 2010. Now they're everywhere. Child poverty rates, which were coming down prior to austerity across the UK, are now all over the place. I've shown you mortality rates. If you look at measures like healthy life expectancy, this is how long people live in good health rather than just how long they live. That should be going up. It's going down. And in the poorest areas of Scotland, people are only living in good health into their 40s. When does a number become a scandal? If you look at mental health trends for sections of the population, they're going completely the wrong direction as well over the same period. You look at maternal outcomes, there is decent evidence of the impact of economic stressors, translated poverty, on things like premature birth rates, on low birth weight babies. We've been doing some work around this as well. And among the poorest areas, we're seeing a big increase in that as well. When I said things weren't good, I wasn't joking. And this originally said, when I said things had gone to shit, I wasn't joking. But that's maybe a more appropriate reflection. So what do we do? Well, the first thing I'm going to do is shut up in a minute and hand over to Jerry. But because we've been writing a lot about this and doing quite a lot and lots of talks and presentations, I do kind of think about this quite a lot myself in terms of what we should do. And my first reaction is always this one, which is just to kind of weep and then possibly weep some more in terms of what's going on. But I also do think very sincerely that there's a responsibility to shout about this, because I don't think enough people know about what's going on and the impact of the last 13 years on inequalities. And I think people are either unaware or maybe don't care. I think it's more the former rather than the latter, but I also think there are sections in society where maybe the latter applies. So I'll just say one last thing before I hand over to Jerry. Obviously at the moment, the COVID inquiry is going on, and you don't need me to tell you about the impact of COVID on society, aside from the whole kind of economic and societal impacts. On a more profound level, I'd be very surprised if there's anybody in this audience who doesn't either know someone or know of someone who died from COVID during that kind of peak COVID period. And what I'm about to say doesn't take anything away from that. But early on in the pandemic, Jerry led some work which was basically comparing the, at that point, projected number of deaths from COVID with the numbers of deaths we get from inequalities in the UK generally. And if you look at the number of people who have died from COVID, that's effectively the number of people who die from inequalities in the UK every year or two. Every year or two. But we don't have independent inquiries and we don't have astonishing government responses to that situation. We published another paper last year which showed that more people had died from austerity than had died from COVID. And we made a big effort to try and get that message out. We've got a great comms team that were doing all sorts of things to try and get the message out. And it was picked up in some quarters. The Guardian ran with it, and of course the Guardian retweeted it to that Guardian bubble of, what does Suella Braverman call them, Guardian reading, tofu eating, wokarati, or whatever she called them. And so people in that kind of section of society saw it. But we also did lots of interviews elsewhere, and I did an interview with the BBC, and I did an OK interview, and they ran with it at 6:30 in the morning. But by 7:30, that story had been replaced by the story of a new college course on keeping chickens. So to an extent, we're operating in a parallel universe, and that's kind of why I think we have to weep before we shout. I'm going to stop there and let Jerry tell you something a bit more constructive and optimistic. Thanks.
Can you hear me okay? Yep. So thank you, David. There's only two things worse than giving a presentation at any time. The first is following David, because he's such a good presenter. And the second is having to provide good news. Are you getting echo? I'm getting echo. Or just bear with me. So the third thing that makes it even more difficult is having to deal with an echo. So I'll switch this off. Hopefully this works. Okay, so hopefully we can do it like this. So I'm to give you some good news about how we might respond to the challenge. So be kind to me here, because it's quite difficult to give good news in the context that David's just talked about. So how might we respond to this challenge? So the good news is that we're not starting with a blank sheet of paper. There's a very, very long history of what we need to do to improve the health of populations. And that goes all the way back to Virtual's report on typhus in Upper Silesia, one of the European areas that David compared West Central Glasgow to. And in that report, actually, they were talking about housing conditions, economic conditions, unemployment, poverty. Even then, in the 1840s, we knew about what we needed to do to improve the health of populations and to reduce inequalities in health. So we've got a long history here. It goes all the way through Engels' report on the conditions of the working class in England and in Manchester in particular. More recently, the Black Report in 1980, The Health Divide by Margaret Whitehead in 1987, Sally McIntyre's brilliant report in 2007, updating all evidence around what works to reduce inequalities in health. The WHO's work led by Michael Marmot, first of all on a global level, and then on a UK level about how to reduce inequalities, again summarising the evidence. A great report, I'm biased because I was one of the authors on this, but a great report by NHS Health Scotland in 2013, which again updated this evidence. There was also a series of reports done off the back of that for different groups, like what can a non-exec director of an NHS board do to implement things around health inequalities. And then there's the reports that David already talked about, which again had long lists of recommendations, all informed by the evidence about what we needed to do. So we're not starting from a blank sheet of paper. To summarise, these reports are consistent all the way back to 1847 in virtual. So what's changed is that we've got a gradual increase in the depth and the quality of the evidence. It's triangulated across different data sets, different teams, different methods, and it's all pointing the same way. The fundamental causes of inequalities in health are inequalities in income, wealth and power, and addressing those fundamental causes will make things better again. And we know that because that's what happened in the first half of the 20th century in the UK, when inequalities in income, wealth and power reduced, and inequalities in health also reduced. Some of us have argued that power is actually quite a good overarching framework here because it also incorporates economic power as a very tangible way in which power is operating in society, but it also includes more recent sort of evidence base around racism and discrimination of different forms. And various people in the room actually had contributed to a paper that describes how power is a good framing for operationalising different actions to reduce inequalities in health at different levels. Indeed, Sharon Friel, who I think is coming to speak at a future seminar series event, has operationalised very similarly in the Australian context, and I would put that in my diary to come and see her speak on that. Beyond that, we know that action on the wider environment, so whether that's about employment conditions, housing, education, they all matter for health. It's not as effective as dealing with the fundamentals, but it still matters and it's still very important. And we also know how important it is to deal with people who have much greater needs, so sort of inclusion health groups, people who are homeless, people who have multiple health conditions that impact on them. And providing bespoke services that meet those needs will also make a difference. A lot of the reports that are described, really from Sally McIntyre and Marmot onwards, have made a lot of effort to look at the evidence around what kinds of interventions work, and especially the kinds of interventions that public health people have a bit more influence on. Because much as we might want to reduce poverty, and much as we might want to reduce income inequalities, often that seems a wee bit out of our grasp, a wee bit out of our agency. But sometimes we have managed to introduce or be part of a system that introduces regulation, legislation and specific taxations. And we do know that they can be very highly effective at reducing inequalities in health. But we must remember, as summarised in the Health Inequalities Policy Review published by NHS Health Scotland, that these kinds of actions, where they are addressing wider environmental causes or individual experiences, will not solve this problem. We need to deal with the fundamental causes, such as lack of power and money, if we are to reduce inequalities in health. I want to spend just a slide or two, though, talking about how we can sometimes get distracted in public health, because I think it's as important to describe what doesn't work and what we shouldn't invest money and time in as it is to discuss what we should do. There was a report published earlier this year by the Health Foundation, which I am very, very critical of, called Leave No One Behind. And it described something of an implementation gap as being the key problem in Scotland for why we have higher health inequalities. I don't think we have an implementation gap problem in Scotland. Indeed, you could argue that these blokes here implemented the austerity programme and the welfare reforms, in inverted commas, that very clearly was implemented exceptionally well and led to the stalling in life expectancy and the worsening in life expectancy trends for the poorest groups. So arguably we don't have an implementation gap, we've got an implementation problem, it's just the wrong policies have been implemented. But we've also had a series of programmes in Scotland that were also about reducing inequalities in health, such as the Keep Well programme. And we know now with hindsight that Keep Well didn't reduce inequalities in health outcomes. And it took us quite a long time to come to that conclusion, and quite a lot of money was invested in that programme. We do have a really big, deep evidence base about the kinds of things that work and do not work. So for example, here's a Cochrane review, and for those that are not familiar with the Cochrane Library, they spend a huge amount of research time consolidating, reviewing, quality appraising, and then analysing the evidence for interventions across all areas of healthcare, whether it's medicines and surgery, or whether it's public health interventions. And just for one example here, there's a huge systematic review and meta-analysis here of whether opportunistic screening in primary care around cardiovascular disease improves health and reduces inequalities. And the answer is a really clear no. And yet that's still part of the policy conversation in Scotland. And yet we still spend time, we still spend money, there's still opportunity costs about interventions that we know don't work. There's also been a bit of a theme in Scotland about using improvement science inappropriately. So you'll see lots of reports about using improvement science to try and assess whether an intervention is effective or not. We wrote up in a paper here that that's a really bad way of assessing whether something's effective or not. It's a really good way of seeing if something that we know already works has been implemented fully, but it's a really bad way about assessing effectiveness. So we need to use the tools we've got effectively. So back to where I think we do have some agency and we do have some influence in the public health system. And I think it's around this idea of the commercial determinants of health. So that can be any sort of industrial kind of process, whether that's the food industry, the alcohol industry, the tobacco industry, gambling, things like that, that has an impact on health. And I want to tell a bit of a long story about how we've been effective in this kind of arena. And if we think about the smoking ban, there was about a 15 to 20 year cycle of us getting that in place. And public health people like you, have been instrumental in making that happen. And that is a really effective intervention that had an impact on reducing inequalities in smoking-related outcomes, including mortality. But it took 15 or 20 years to get the evidence together, to disseminate that evidence, to produce that evidence in briefings and formats that different users could use, whether that's advocacy groups like Ash Scotland, or whether that was politicians or the media. We had to resist the merchants of doubt, the people who opposed that, the people who were making profits out of those kinds of industries, in this case, the tobacco industry. And you'll be aware of all of the legal challenges, all of the misinformation, all of the doubt that was created by the people that were set to profit from it. And then, of course, in the case of the smoking ban, we had the Irish example where it was implemented, and the First Minister at the time in Scotland went across and was really impressed and thought, actually, maybe we can implement the smoking ban in a Scottish context. And then we implemented and we evaluated it, and we found out, actually, this had a massive impact on a whole range of health outcomes. So it takes time, it takes persistence and resilience, but we all have a part to play. Some of you might have played a part in different parts of that cycle. A similar 15 to 20 year cycle is just kind of coming to an end around minimum unit pricing for alcohol. But we could talk about this kind of 15 to 20 year cycle for lots of these commercial determinants of health. And arguably, we're just a little bit earlier on that process for things like poverty reduction and austerity. We're still reviewing the evidence, we're advocating it, we're disseminating it, we're resisting the merchants of doubt. But we're just trying to get those politicians to get engaged in it and to implement that so that we can then evaluate those impacts. And arguably in Scotland, we've got some attempts in that way, like the Scottish Child Payment, which is making a bit of a difference to mitigate against some of the austerity policies coming from the UK government. So I think we need patience and persistence in tackling power as seen in the commercial determinants of health. But I think there's lots of scope for us to use more forms of legislation, regulation and taxation. And we've got lots of evidence about the kinds of things that we know works. So it's always astounded me that we don't use that evidence particularly well. For example, there's a really good systematic review and meta-analysis that shows, in the context of the USA of all places, that bringing off licences for alcohol into public ownership is a really effective way at reducing alcohol harms and alcohol-related deaths. And we've known this for 20 years, but we're not really discussing that as a possible option in Scotland. Why not? Well, it cuts across a lot of commercial interests and a lot of power. But if we're really serious about this, lots of other countries do it. Iceland does it, lots of the Nordic countries do it. Why are we not introducing these kinds of interventions, which are pretty much cost-free, that could have an impact on health and health inequalities? We also need to address the obvious gaps in the commercial determinants, like food, like landlords. There are also new commercial determinants of health coming on all the time. So gambling, new forms of gambling, like online gambling, in-game gambling, vaping, the digital media. Again, there's a huge lack of regulation in there, and they're all having mental health impacts. But the sort of common theme through all of this is that we do need to address the power differentials within that and the commercial interests. And that will be challenging. We will end up in court, I'm sure, trying to persuade people that the evidence is there that these things work. But public health as a community has a role about providing the evidence, making that advocacy, and giving politicians a bit of steel for acting, because it can be difficult to make those kind of political decisions where they're not always popular initially. But I'm not sure if many people would want to go back to smoke-filled pubs. I remember vividly coming back in my student days from going clubbing and my clothes absolutely minging of tobacco smoke. Nobody really wants to go back to that now. I think we've also got scope to sharpen our understanding and recommendations when we are straying into ideas about the economy. And David's talked a lot today about politics and the economy and how we know that is fundamentally important to driving the trends in health inequalities. We've done some work recently to understand and address what we understand about economic relationships between social groups. So quite often in the past, we might have said, we just need to reduce poverty. We need to include a new benefit. We need to perhaps change taxes. And all of those things are true, and we should do them. But we need to also understand how money flows in society, how money flows through rental incomes, for example, from tenants towards landlords, how profiteering and monopoly capture means that some people become very, very rich. And we don't need to look too far to find billionaires in this world now who are making excessive profits from many of us. And all of these other economic mechanisms too. And the way to address these underlying economic relationships is about thinking about economic democracy and plural ownership of different parts of the economy. There are colleagues within Public Health Scotland who are doing a review about what works to understand that and what the kind of health impacts might be around that. That's a really live topic now. But it's also being implemented in different parts of the UK, usually under the banner of community wealth building. This is a study by a team at the University of Liverpool looking at the city of Preston in northwest England. And Preston was the earliest adopter of the community wealth building approach. And it involves a range of different things around using the procurement and supply chains of the public sector to try and make a difference to economic outcomes and reduce economic inequalities. But it's also about changing the ownership structure within local areas and trying to introduce more cooperatives, workers' cooperatives, social enterprises, and more public ownership as a means of trying to stop that wealth leakage towards the very, very rich. And what this initial study finds is that mental health outcomes and self-rated health get a lot better when you implement community wealth building. It's a really robust study. We also have opportunities in Scotland to get involved in conversations and make a difference around basic income, around the minimum income guarantee. I've been involved in policy conversations around that, and we've been able to use public health evidence in those discussions. There are live discussions, as everybody knows, around child poverty. But we've also got an opportunity, I think, to study up and think about power inequalities in society. And there's a big literature out there. I'm now sitting in a sociology department rather than a public health department. And I've learned a lot from my colleagues in those kinds of departments about how to do that kind of work, how to understand the sort of genesis and maintenance and replication of inequalities through power networks in society. And I think that's really important, not least today when this chap has made a decision about reducing employment in the Forth Valley. We've also got opportunities, I think, to try and get co-benefits because we know we need to make a transition really quickly if we're to avoid the worst excesses of climate change and biodiversity loss. And we do know as well that it's possible to get spin-offs so we can get health outcomes and equity outcomes as well as sustainability outcomes with the right kinds of interventions, whether that's around moving people onto public transport and active travel with our transport policies, whether that's about retrofitting our housing so that we can reduce our carbon, improve our health, and reduce inequalities. So there's an opportunity to get involved in those kinds of conversation, I think, so that we achieve the so-called just transition that improves health as well. In Scotland, we've got this framing of a wellbeing economy, and that's a really useful framing for this kind of new economic design, but it's contested, and it could be lifted and misused by people who don't share these kinds of aims. And so again, within public health, I think we've got a real opportunity to infest the wellbeing economy discussion with evidence, with data, and with advocacy for health outcomes. We're not alone in thinking like this, though. So the WHO Council on the Economics of Health for All published this report earlier this year. That commission is an all-female panel, and it's come out with really, really clear recommendations about the need for a different kind of economy. So they asked, what would it take to create economies that serve these objectives, i.e. health, equity, and sustainability objectives, rather than profit for a few? How can we create metrics or outcome measures that reflect what is ultimately of value? And in doing so, they're challenging international institutions to think differently about what the purpose of an economy should actually be. We've got good examples in Glasgow. This is Green City Whole Foods. I had the privilege to go and visit them last year and do a podcast with them about how they work. Green City is now 40 years old. It employs almost 60 people. It's a genuine workers' co-op where everybody has a say in how the workers' co-op runs. Everybody gets exactly the same pay. It is the most fun workplace I have ever experienced in my life. Every morning when you go into their warehouse, there is a debate about whether it's going to be bagpipe music or Swedish house music that's going to be playing in the background. There's a gorgeous area of the warehouse which has got all their spices. But more importantly, they have been making a difference across the supply chains of Scotland for 40 years now. They supply ethical foods, they supply fair trade foods, they supply vegan foods, and they are generating supply chains that meet the kinds of objectives I was talking about. So they're achieving equity through their workplace practices, they're achieving sustainability by moving people away from high carbon foodstuffs, and they're achieving health outcomes through the best practice around workplace and around income and employment practices. So we have good examples, we've got places that we can point to and learn from, and these are good stories, good news stories that David asked me to talk about. I'm going to finish just with a slide about what a population health strategy might look like, because the Scottish Government have started a conversation about what that might look like as a means of coalescing these kinds of ideas and in response to the kinds of challenges that David laid out. And I think fundamentally, as David said, we need to recognise that inequalities in power, income and wealth are the central challenge, and in particular the role of UK economic policy in driving the health trends. And I think we need to recognise that, but within a Scottish context, it can be quite difficult to fully address that. I think we need to think about our national performance framework and the national outcomes. So what are we trying to achieve with policy across Scotland? What actually delivers those outcomes? So if we were to say that health and health inequality and ecological sustainability were the outcomes we're interested in, would we then still have the same policies in place? Because at the moment, GDP, for example, is up there at the top, and it says, well, we need to have an economy that delivers faster growth. That's fine if faster growth will achieve these outcomes, but I'm not awfully convinced that that would necessarily be the case. What would an economy look like if it was actually reorientated and designed to achieve health, equity and sustainability, i.e. the genuine wellbeing economy? And I think we should use evidence, effectiveness evidence, to guide policy decisions. We know a lot more now about what works. There's an increasing number of systematic reviews being done of the evidence around economic policy. For example, discounting things like the Laffer curve, which suggests that higher taxes actually reduce tax take. We know that that's not true from these kinds of reviews now. We also need to use the capital investments, the amount of one-off monies that we have to invest more sensibly. For example, we've got a massive gap about getting housing retrofit so that we don't have excessive energy costs across particularly our social housing. Why are we not using the capital monies that we have to invest in these kind of things that would have this win-win-win kind of outcome? But more within the powers of people in the health department of the Scottish Government, maybe we need to develop and implement an evidence-informed legislative programme across those commercial determinants of health. Both the old ones like tobacco, because there's more to be done on that, but also the new ones like gambling, like digital media, and so on, and use the existing powers that we have around the Public Health Act to create the kinds of legislation that would improve health and reduce inequalities. We need to deepen and broaden what our ambition is around community wealth building. For example, we do an awful lot of research into pharmaceuticals across UK and Scottish universities, but that wealth is extracted by big pharmaceutical companies. Why don't we have an NHS board that deals with trials in pharmaceuticals? We could retain that wealth within the NHS. Maybe we need to think more ambitiously around that. I do think it's really important that we disinvest, i.e. stop things that we know don't work. Money is really tight. People's time is really tight. We can't afford to keep doing things that we know don't work. That can be one of the most difficult things for people like us to do, but I think that's one of the challenges that we need to engage in. And then lastly, I think we need to take equitable healthcare seriously. We don't, often in public health, we spend a lot of time saying, you know, it's the social determinants of health, it's the commercial determinants of health, it's the economy, and it is all of that. But healthcare does also matter. And we do need to think more seriously, I think, about how we make sure that is equitable towards people's needs. And that includes a focus on inclusion health, it includes a discussion around funding allocations and proportionate universalism, providing according to need. Thank you very much to the GCPH for the invitation to speak. Thank you to the huge number of people who have co-authored on all the range of underlying publications. Credit to whoever Testicle 89 is for the picture of St Mungo that I nicked there, and also to Cat Smith for the idea of using murals on my slides. And thank you for not heckling. I don't think I said one single heckle. So I'll hand back over to Danny, and I think we're going to have a panel discussion now.
Thank you so much to you both. I think even if you know, I think you know an awful lot about austerity. Hearing it, the impact outlined, the impact on health inequalities outlined so starkly is pretty shocking. And there's been a lot of food for thought there for me as a journalist as well, and what I can personally do to change the headlines and change the narrative a little bit. I wonder, would it be okay? Would you come up and join me? Thank you. So we're very lucky to have with us also Dave Moxham and Donna Milne. Donna is Director of Public Health and Health Policy at NHS Lothian, and prior to joining NHS Lothian, she was Director of Public Health in Fife. She's worked in children and young people's health and education within local authorities, the voluntary sector, Scottish Government and the NHS. And Dave Moxham is Deputy General Secretary of the STUC with lead responsibility for a wide range of policy areas, including cost of living crisis, just transition and transport. He's represented the STUC on a wide range of bodies, including the Just Transition Commission and currently the Scottish Government Tax Advisory Group and Fair Work Implementation Group. So thank you both very much for joining us. I wonder if before I come to them, I could just ask, one of the things I was thinking of while I was listening to you both was, you know, it's very positive to hear that there are ways forward, but in the climate we're in just now, the political climate, I mean, these require political will, and we know that even politicians who are ideologically inclined towards tackling poverty and who talk a good game on progressive taxation tend to run scared when elections are coming up. I wonder if, you know, is there anything that can be done to kind of encourage them to be braver? What can we do?
So I suppose in public health, the main thing is about the evidence. So it's not, I mean, I was speaking at a different thing last week and I had that on my slide saying we need to shout about it, and I was kind of questioned, well, there's no much point just shouting. So it's not just shouting, but it's actually saying, as Jerry was pointing to, that there's just so much evidence around this now, and it's about trying to persuade people to understand the evidence. You know, in terms of the whole kind of, is there any money in the system? People, because we talk about, you know, everything that's going on, cost of living, etc., it's kind of easy to forget that we are in a massively, massively wealthy society. Scotland is massively rich. The UK is massively rich. It's just obviously, as we all know, it's all massively unequally distributed. So it's about trying to point to these facts and to the evidence of what's going on to try and make people of a particular political persuasion, especially if especially at Westminster level, there's going to be a change of government, to try and understand what's going on and try and understand that I think it's their moral obligation to do something about it.
And do you think if people were more aware, like you talked about, if they were more engaged, do you think people are more inclined to back higher taxation than politicians sometimes fear?
Well, there are public attitude surveys around this kind of thing, and generally they do show a little bit more appetite than politicians sometimes portray. But there's also a kind of, dare I say it, a commercial determinant of health here, which is the media. So we're all, I mean, traditionally we would have got the media from, you know, newspapers, and there's obviously a very skewed ownership structure around that, and it's become even more skewed over time. In fact, from what I gather now, and I'm no expert on this, we all see our news very differently, because most of us now get our news from digital media, and you know, your Facebook feed or your Instagram feed or whatever will be very different because it feeds you and pushes more and more of the same kind of stuff towards you. And that's kind of what I was getting at to a degree around, you know, we need to think about digital media as a commercial determinant of health, but also as a kind of commercial determinant of democracy and how that frames democratic decision making, because a key component of democracy, I guess, is having access to the truth, and having access to the evidence is totally legitimate and important that people have different views and different values and different perspectives on that. But there are some things that are just true, and you wouldn't necessarily know that from the media that we have at the moment.
Yeah, it's a better communication, really.
It's also about, again, it overlaps with the answer about evidence. So there's been a lot of stuff done. Kat Smith is in the audience. She's done a lot of work around where you speak to people, you speak to panels of people, and do you think you would be happy with these particular policies, and they may have a particular view, but then you show them the evidence of, you know, how that could be used to make society better, and you know, people do listen to the evidence and then change their views. So I think it does come down to an understanding of what's going on and making people aware of what's going on to a much greater degree.
So like you said, shout about it.
Yeah,
Shout about it. Donna, could I ask you, I mean, obviously everything that Jerry and David said has been an indictment of austerity policies. In your many roles in health and education, you know, what have you seen in the last decade? How has it played out for you? And what's your response to what they've been saying?
Thanks, Danny. So I've been frantically scribbling. Sure, of course. Is that any better? No? I'm one of those gentle Edinburgh girls, I think. You know, we don't shout, David. We tend to get a bunch of folk in a room, give them a cup of tea, and then try and convince them that really, really you do want to think the way we do. And the evidence we have in front of you is compelling. And maybe you should take a wee bit of action about it. So I'm just kicking off with that. When I saw the slides earlier, I was thinking it maybe as a subtle message, but it really wasn't in terms of the political stuff. And Danny, you've asked a question about what we've seen in the last 10 years, and I think things have just got harder in the last 10 years. They've got harder for everybody. Not for everybody, sorry, but for those who are struggling just to get by, who don't have enough money to live on, who don't have decent housing, who are struggling to get good work. And then those of us in the public sector who are trying to support them and to change policy and to improve people's lives, we've seen reductions in public service, infrastructure and investment. So you've got those two things together, and I think that just makes it really, really difficult. I did say to Jerry earlier on, I am a glass half full person, so I'm quite keen to come on to the what to do bit too.
So, I mean, what initiatives have you seen that do work? I mean, I'm thinking of things like the deep end, you know, grouping together the deep end surgeries, community links practitioners. What have been the things that you've seen that have worked pretty well?
So I guess I have some personal favourites that I've seen in other parts of the country, and I've not always managed to get them delivered up here, and I don't know if some of my colleagues around the room would agree, but I do think some things have shifted in the last 3 to 5 years in terms of how we think about things. Both of you spoke, I think, about community wealth building, spoken about wellbeing economies, we're talking about anchors work. I think some of that is capturing an imagination, and it's also a bit more tangible than some of the public health stuff that we've talked about in the past. So Danny, I've seen examples whereby health trusts in England have tried to recruit and give people apprenticeships The young people coming forward have not been able to take the apprenticeship because they couldn't afford their accommodation. The Trust has gone a step further and given them accommodation, refurbished hospital buildings and given them accommodation. So they get a job, they get a house. And as a young adult, that makes a huge difference. And I don't think we have made enough of that here in Scotland. I'm hoping we will as part of our Anchors work.
So where there are positive developments, you're always fighting against the financial constraints, so aren't you? Even when those initiatives are brought in, and you're saying we haven't made enough of them here in Scotland, but even where they are brought in, the next thing you hear is, oh, they're going to be cut, and yeah. So how, is it hard to keep optimistic? Yes.
I don't ever get up in the morning and think I don't want to go to my work, so I must be naturally optimistic. I think we have a fantastic public health community in Scotland. I think we have focused on evidence, we've got amazing data, and we should be able, for the size of this country, to get our key folk in a room and convince them of some of the things that we want to see happen. So as I said, Danny, my glass is always half full. I do think our government colleagues have a really tricky job in trying to get these things into policy. And then, as Jerry highlighted so beautifully in the slides about smoking and minimum unit pricing, we're in it for the long game, aren't we, in public health? And it's how do we get our allies, who else do we need to speak to come with us on that longer term journey, because that's what we need.
Yeah. And Dave, I mean, sometimes when I think about health inequalities and poverty, maybe I think more about people who are unemployed and who are on universal credit and facing all of that. But you're seeing, obviously, employment precarity, 0 hours contracts, people in low paid employment. You know, how does that, you know, tally with what David and Jerry have been saying?
I was relatively pleased, I suppose, to find that Jerry's solutions slide, the policy stuff, both in terms of kind of direct interventions, smoking ban and others, but also some of the wider positions on everything from retrofitting to others do correlate with SGUC policy. It's nice to come to a position from a different starting point, I guess, which is, you know, how are our workers and their families faring in the jobs market, but also out with the jobs market. We consider our mission to represent people in work and out of work. And we have certainly been influenced, I think, by the inequality dialogue over the last 20 years. So you will see trade unions more than they used to, what we call bottom protecting our wage claims. So if you see most of the wage claims, and we've been quite successful over the last couple of years for a change, you'll see offers which are about £1,000 or 3 or 4%, whichever is higher. So we have been trying to look, I think, quite carefully at how within the workplace we do that. One of the problems that we face, and we're trying to address too, is, of course, very often the people in the worst jobs are the ones who are least likely to be in a trade union. So we've been trying very hard recently to find out ways in which we can collectivise hospitality workers. We've been doing a lot of work recently around the National Care Service and how we can lift trade union membership and obviously pay in that sector too. So we do see it as a fundamental, the workplace and work-related issues as fundamental to this, but we don't think that's enough, and we do think that we've got a role in wider public policy, including health policy, which I'm happy to talk about till the cows come home, but I'll shut up just for a second.
I suppose, I mean, you're talking about there some of the, well, Donna was talking about some of the things, the initiatives you can bring in, but we were also talking about how it has to be systemic and wider, and I wonder how you feel things like the Scottish Child Payment have made a difference, and how something like universal basic income might make a difference. You know, are these, and how likely is that to ever be a realistic proposition?
Two different halves quite quickly to answer to that. Yeah, the Scottish Child Payment, you know, credit where credit's due. The evidence says that it's positive. We've been working with civil society organisations, Poverty Alliance, Child Poverty Action and others to make sure that that's the case. no criticism. I think everyone understands that it's still quite at the symptom level that we're dealing with that in terms of fundamental inequalities and poverty. But you've got to do what you can to deal with the symptoms, and that's certainly been positive. We don't have an issue with minimum income guarantees. I think we're a long way from winning the political argument. It comes a bit back to that discussion about taxation and the wider contribution that's expected from society in order to provide everyone with that basic income. I think there's a lot we can do and a lot we need to do to win that argument, and there's an awful lot that we need to do over the next 3 or 4 years to change our whole tax base so that we're taxing wealth a lot more and income a lot less, and we're going to need to get rid of that horrible council tax as soon as we possibly can.
Just to chuck something in there, so one of the themes of this whole seminar series is that it's 20 years since the first one, and 20 years ago there was all sorts of analysis done around child poverty, and there's been books published as well, and they would list like the top 10 worst places in the UK for child poverty, and 20 years ago 7 or 8 out of 10 would all be in Scotland, and most of them are in Glasgow, and now they're not. Now they're mainly in the northwest of England. And it's not that things are fantastically great here, it's just that they've got a lot worse in England. And so this is about sort of mitigation. And so things like the Scottish Child Payment help enormously. It's clearly not enough, and everybody knows it's not enough, but it helps enormously. And the trends south of the border are way, way worse.
Mm-hmm. I mean, that's interesting because sometimes you feel like there's a negative narrative there that, successive governments have promised to tackle child poverty and nothing's happened. And yes, it is only mitigation, but I mean, that's something, isn't it? Yeah. I can't really ignore the fact that we're sitting here the day after the autumn statement, and I guess I'd like to ask everybody whether there was any bright light at all out of it, even the increase in the national living wage, and whether it flies in the face of some of the things you've been saying. But obviously, again, we'll be looking towards another government and what you would hope from that.
I still insist on calling it the national minimum wage, not the national living wage, and it still falls short. It was, I guess, in inflation terms, it was roughly speaking what was needed if we take into account the inflation rate, RPI rate on the things that poorest people buy most, foodstuffs, and others. The national insurance cut will be of some assistance to lower paid workers, but taken together, it's a horrible budget. We're talking, probably the next chancellor of the next political party is likely to inherit a planned austerity program, the likes of which we've never seen. So it's an absolutely dire state of affairs. And one which, I think the Scottish Government can mitigate to some extent, and it's got its budget coming up, and I wouldn't want to be Shona Robertson delivering the Scottish budget, but we do think that there's some things that the Scottish Government can still do in terms of mitigation, in terms of changes to the tax base, which can mitigate what, frankly, is a pretty awful situation down south.
I'm a kind of glass half empty kind of guy, you might have noticed. But actually, there was an interesting thing on the radio yesterday, which I went to check it was actually true, because they were talking about the increase in the minimum wage, but they call it the living wage. And somebody was just saying, but actually in Scotland, 92% of employees are actually on the real living wage, and I thought that can't be right, and I went to check, and it does appear to be right according to ONS figures. And I thought that was quite encouraging, given the big kind of drive from the Scottish Government to get people signed up as real living wage employers and all the rest of it. But generally speaking, it's not a happy thing. And I think I would just point to Jerry's slide around all the recommendations. We spent quite a lot of time in various reports talking to people in like Oxfam and Child Poverty Action Group and coming up with sets of recommendations that have to be done at the political level. And that's what we need to do, not what was done yesterday, effectively.
Donna?
I'm not sure I'm that hopeful, actually, after yesterday. I guess one of the things, Danny, that really disappointed me was, yes, we saw the increase around the living wage, and we saw that change and come in at age 21, I think, instead of age 23. What a missed opportunity to bring that lower. That one of the fundamental inequalities that we see at the moment is just the way in which our younger folk are treated. We expect them to, take on the jobs that we have at the moment, to care for all of us in the future, and we won't even give them a decent pay for the job that they're doing. So I was a wee bit disappointed. I was kind of hopeful that one might have been picked up.
And then we slag them off on top of all that. In the press and the media and that. Yeah. Chair.
Did you want something positive? Sorry, was that the?
Your
Okay, so
positive
well, it could have been
person.
worse. It could have been worse. So there was a fear that like benefits weren't going to be uprated at all. So I was very worried that might happen, and that didn't happen. But in the glass half empty side, notwithstanding what David said, the inflation rates that are felt by the poorest groups are much higher than RPI. So we did a study looking at modelling or estimating how much the higher inflation that we've seen over the last couple of years was likely to impact on mortality rates. And we estimated that the inflation in 2022 would increase mortality rates by 6% across the board. But it was 8% in the poorest 20%, and it was 2 or 3% in the richest group. And that's because a much higher proportion of people's income in the poorest groups is spent on the things that were rising quickly, whether that's gas or food. And so actually, the real inflation rate for most people who are on benefits is much higher than RPI. And so they will see living standards drop further in the coming year, notwithstanding the other conditions that were also put in people's benefits, which will, again, be more likely to see people sanctioned and made destitute. So it's difficult to be too optimistic, but I guess it could have been worse. It can always be worse.
Do you see any signs that a Labour government would be a great improvement then? Are you? Are there any policies that you can highlight that might be a little light in the dark?
Yes. Okay, let's be positive. So the Labour Party at UK level do still seem to be committed to new forms of public ownership around transport, for example, and that would reduce some of the rent-seeking behaviours that we see from big companies like Arriva, McGill's, yada yada, and that could then improve employment conditions and reduce costs for the poorest group. So yes, that might help a little bit.
There's Jerry being optimistic, and then I'm going to ruin it. So I think one of the most dispiriting things I saw was the discussion around the two-child cap. The two-child benefit cap is sort of seen as quite kind of emblematic of austerity in terms of all the policies, the impact it had in driving child poverty rates. There's loads and loads of evidence around all this. And so, again, it comes back to that word evidence. So are people in the high levels of Labour Party just completely unaware of all that evidence? I kind of assume so for them to say openly that they're not going to do anything about that. And that's only one. There was I think it was in the first Parliament from 2010, there were 150 different social security cuts made. I mean, there's astonishing things going on, but there are certain ones which kind of really kind of echo and really kind of relate to people, and the two-child cap is one of them. And so it's just quite kind of astonishing that they're basically saying they're not going to change anything. But again, I think that then becomes incumbent on all of us to try and kind of make them change their mind and try and understand, as I said before, the evidence of what's been going on.
Did you want to say?
Yeah, I'm slightly pessimistic. I mean, there's three things, I guess, that a UK Labour government had broadly committed to, although there's been quite a lot of tempering of commitments, is probably the kindest way to say it, over the last number of years. I mean, one was reform of care. And obviously that would reflect in Scotland in funding for a national care service. Sometimes it's these double win things because it's better wages for people who provide that vital service, but it's also about family, community cohesion, and obviously about health itself. So that's one thing we'll be saying. You were committed to that. The second, I think, is around transport. I think that the need for a publicly owned transport system, including a bus system, is absolutely vital. And again, it's a kind of double plus good because it can be a job provider, it can assist with emissions. And the third, I guess, is around energy and in particular retrofit, in which Jerry mentioned on the board there. I mean, a government-led, municipally delivered retrofitting programme is probably arguably the most transformational thing that we could do. Now, people can argue about other priorities, but you are providing decent jobs very often for the young people who are being left behind just now. You're dealing with, or at least addressing fuel poverty, and you're addressing climate change all at the same time. And one would hope that it will be very, very difficult for a Labour government not to hear those voices, and obviously there would then be knock-on effects for the Scottish government depending on the form of funding in terms of Barnett consequentials. So, let's keep our eye on the prize, although I'm not being filled with hope over the last year, given some of the pronouncements that we've had.
Thank you so much.